Health Summit. I think everybody's trickling in, but if we could sit down and switch off our mobile phones, the chief guest, His Excellency, the Lieutenant Governor of Delhi, Mr. V.K. Saxena is on his way, so if you could just settle down, I'll ask. We've got a really long and fruitful food for thought day planned. And I'm going to put on my spectacles. And I'm sort of, so welcome again. We're going to start the program with the Lieutenant Governor, and he's going to do a keynote address. Can I request everybody to stand when he comes? I'll sort of alert everybody and remain standing because we're going to play the national anthem, and then everybody can sit down, and then we'll have him to give us his words of wisdom and continue the day. Thank you. Can, can I request? Can I request Stanley Thomas, Senior News Editor, to give his welcome speech?
A very warm good morning to all of you. See, one evening last week, I sat in a hospital cafe waiting for a cup of tea. While waiting, my eyes wandered to a neighboring table, over which two young doctors were almost bent over, staring quietly at their cup of coffee. Even while I was sitting some steps away from them, I could sense their fatigue and feel their aching bones. This was late in the evening. After having my cup of tea, I went back and resumed my wait outside the OT. A relative was undergoing surgery inside. A few minutes later, I noticed the two young doctors I'd seen back in the cafe striding back to the OT. And then, in a jiffy, they disappeared inside the OT complex. Their purposeful and brisk walk, with head held high, did not betray the fatigue I had just seen some minutes earlier. This, I thought, is a doctor we seldom see during our regular visits to any institution. Doctors and healthcare staff are many times unseen, often unblinking. But then I told myself they are busy elsewhere. Their work giving hope and strength to us and to our loved ones. The scene that I mentioned happens every day in every city across this vast land. The week's latest issue on the best hospitals of India is dedicated to such doctors and healthcare teams across this country. This issue is not just a humble way of honoring our healthcare staff, it is also a small thank you to all of you. Every time we undertake the Best Hospitals survey, we feel it is the first time we are doing it. So much is our eagerness to add something more as a layer of new information. And along with our survey agency, we spend about 4 months understanding the methodology and trends in treatment, because this particular issue you must have seen. You have the survey at the heart of this issue, but around it are wrapped number of stories taking note of trends and the best of our healthcare professionals across India. As I said, the survey process itself is 4.5 months. And during that time, the survey agency speaks to more than 200 hospitals across 17 cities, plus the National Capital Region. Some 2,000 plus doctors across 10 major specializations are contacted for views, ranging from infection control to treatment outcomes, to research and innovation. Each place must be throwing up something different. That's expected. The survey agency also visits some hospitals during these 4 months to check aspects of the information shared by them. This 2022 edition of the Best Hospitals issue is the 19th year of this All India exercise that ranks both government-run centers of excellence and our private institutions. Today, it is to honor some of India's finest hospitals that we have the pleasure of receiving His Excellency, Mr. Vinay Kumar Saxena, the Honorable Lieutenant Governor of NCT Delhi, as chief guest of the Best Hospitals Awards 2022. Sir, amid a hectic late November schedule, you have accepted our invitation, not just to honor these award winners, but I feel through these award winners, you are honoring millions of healthcare workers who have healed us, held the hands of our loved ones, and seen them to the shores of safety. A warm welcome to you, sir, to the Week Awards as our distinguished chief guest. Our guest of honor sitting on the dais is the much-loved Dr. Randeep Guleria. Many of you may have seen him. A lot of you know him personally. The masses of India made him our own, especially over the past 2 years of our tryst with COVID-19. Some among the public consider him Dr. Cool for the calm manner in which he separates truth from the swirl of rumors. Thank you, Dr. Guleria, and welcome to the Week Awards. Dr. Guleria will deliver the keynote address this morning. And a warm welcome to our panelists, and it is made up of such eminent names. Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals Group. Dr. Devleena Chakravarti, Managing Director of Artemis Hospitals. Dr. Santosh Shetty, Executive Director and CEO at Kokilaben Dhirubhai Ambani Hospitals. And Dr. Anand R., Head Quality at Manipal Health. They will, in a short while, be looking at a very important discussion on the challenges and opportunities when it comes to enhancing quality in healthcare. And we have a wonderful audience today. Thank you very much. Heartfelt thank you to each one of you for your presence and your support. It's a pleasure to welcome distinguished doctors, among them specialists, CEOs, technocrats. Whatever your role, what binds you, all of you, is a love of people, I think. A love of people you don't know, but you end up touching and saving. Can there be anything better than that? The week welcomes you, such wonderful warriors, with humility and gratitude. Thank you.
And now it's time for the awards. I would request His Excellency, the Honorable Lieutenant Governor of Delhi, to please hand out the awards as the best multi-speciality hospital, All India, goes to the All India Institute of Medical Sciences.
Audio Jungle.
next set of awards are the best multi-speciality hospitals in zones. So the best multi-speciality private hospital North Zone goes to the Medanta, the Medicity in Gurugram. Best multi-speciality private hospital in East Zone is the Apollo Multi-Speciality Hospital in Kolkata. Best multi-speciality private hospital, South Zone, Christian Medical College, Vellore. Best multi-speciality private hospital, West Zone, Kokila Dhirubhai Ambani Hospital and Medical Research Institute. The next set of awards are the best multi-speciality hospitals in metro cities. The best multi-speciality hospital, Delhi, goes to the Indraprasth Apollo Hospital. Speciality Hospital, Mumbai, goes to Kokila Dhirubhai Ambani Hospital and Medical Research Center.
Audio Jungle.
The best multi-speciality hospital, Bangalore, goes to Manipal Hospital, HAL. The best multi-speciality hospital, Kolkata, Apollo Multi-Speciality Hospital. The best multi-speciality hospital, Delhi NCR, Medanta, the Medicity, Gurugram.
Audio Jungle.
Got delayed. So the best multi-speciality hospital, Chennai, goes to Apollo Hospitals. Thank you, His Excellency, the Lieutenant Governor, Ms. V.K. Saxena. Could I please request him to come and address us? Sorry, I will take all my things.
Former Director of AIIMS, Dr. Randeep Guleria ji, Editor-in-Charge, The Week magazine, Shri V.S. Jayesh Chandran ji, Senior News Editor, The Week, Shri Stanley Thomas ji, members of the media, members of the health sector, and my dear friends. I'm happy to present amongst you on this occasion. At the outset, I would like to extend my hearty congratulations to the winners of the awards in various categories. I hope that this recognition will spur you further towards achieving excellence in the human service that you, as individuals, and your hospitals as institutions provide to humankind. Ladies and gentlemen, it is said adversity brings out the best in us. As the COVID-19 pandemic spread across the world, while most of the advanced countries in Europe and elsewhere reeled under it, India calibrated its response systematically and dealt with the situation with unprecedented innovations and ingenuity. The manner in which we were able to provide for food and other essentials during the lockdowns and vaccinated 1 billion and more of our people has indeed been a remarkable feat. Indeed, there were problems about oxygen availability and drug shortage, and we were faced extremely critical situations, but we faced this situation with fortitude. Thanks to the thousands of our healthcare personnel, doctors, and nurses. Some of the leading lights of that war on the pandemic are seated here, and I salute them. The media played still a role during the pandemic, pointing out and highlighting where the problems were occurring, and that helped the administration to focus attention on the problem areas. As the world is limping back to the normalcy, it became clear that not everything happened during the pandemic was bad. Big innovations in health care technology and pharma industry happened during that period, often because the urgency necessitated the pandemic. The COVID-19 pandemic changed the world as we knew it. This was also a period when the Week magazine came up with some of its best stories. It was first Indian magazine to talk in detail about the looming threat when it did a cover story on the pandemic from China in February 2020 by its own reporters who had gone to China. While most publications focused on the consequences of the spread of the virus, the Week embarked on a mission to find its origin. In June 2021, it published a cover package on the discoveries of Dr. Monalika and Dr. Rahul, a scientist couple from Pune who had been on an online expedition to trace the origin and, of course, the virus, and it strongly suggested further investigation on the lab leak theory. The Week carried an exclusive interview with Chinese virologist Dr. Li Mengyan, who alleged that the SARS-CoV-2 was made in Chinese government laboratories. I have given to understand that coverage of healthcare by the Week magazine is not something triggered by the pandemic. The Week has been publishing the fortnightly supplement Health for the past 15 years. In fact, the survey and the awards that they have published now and for which we are giving the awards today is into its 19th year. I would like to take this opportunity to also highlight and bring to your notice the endemic of air pollution, water pollution, and mounting solid waste that the national capital, Delhi, has been living with for years together. None more than you would understand and appreciate the environmental and health hazards that these pose. Even as we grapple with the ways and means to address the challenges posed by the former two, we have been able to make a substantive beginning in the disposal of solid waste of late. And this seems to be on the right track of reaching its logical conclusion. all of us see these unseemingly and stinking mountains of waste, the east, south, and north of Delhi. These are mountains of legacy garbage that we have come into existence because of Delhi's waste getting dumped at these sites over the past 3 decades. We generate about thousands of metric tons of waste every day in Delhi. And this waste, after being picked up by MCD, is dumped at these sites. Delhi has a small geographical area with a huge population, and no other neighboring state will give us their land to dump our waste. When the Prime Minister Modi flagged these unseemingly health and environmental hazards as the capital's mountains of shame on 2nd October 2019, on the Swachhata Divas, the total legacy waste accumulated at these 3 dump sites was to the tune of 280 lakh metric ton. The Municipal Corporation of Delhi made several efforts to get rid of these mountains. It did achieve success, but to a limited extent. Between 2019 to June 2022, 15 lakh metric ton of waste was disposed at the monthly disposal rate of 1.4 lakh metric ton. Segregation of solid waste through the process of trommeling and its disposal on principles of recycle, reuse, and reduce is an environmentally sustainable manner is what bioremediation is mostly all about. Apart from existing legacy waste, at the 3 dumping sites, Delhi generates about 11,000 metric ton of waste every day. We increased the number of trommeling machines from 6 to 50 during the last few months. 25 new trommeling machines using German technology have further been added about a week back, and these machines are converting waste into far many more reusable products than earlier. Processing of garbage through trommeling machines produces following 3 products. Inert. Inert means soil and dust. Construction and demolition waste. And third is refuse-derived fuel, that is RDF. Friends, a step forward in the direction of using these segregated waste at present, about 8,000 metric tons of RDF is being consumed at 4 waste-to-energy plants in Delhi. That leads to production of about 100 megawatt of electricity every day. We made a public appeal to lift inert and CND waste from landfill sites free of cost for their use. I am happy to share that appeal has received very good response from the people, and in less than 5 months' time, over 40 metric thousand ton of inert and CND waste have been lifted by the people at their own cost. NHAI is the biggest consumer of inert and CND waste. We roped in NHAI with a request to lift our legacy waste. NHAI has committed to consume about 30 lakh metric ton of our landfill sites. We did a comprehensive study of measuring the gross calorific value of RDF, and upon finding it suitably competitive, made an appeal to all cement companies to use RDF as a fuel. An MOU was signed subsequently with the cement company for lifting 50,000 metric tons of RDF annually. In less than 2 months' time, 4,000 metric tons of RDF has been lifted by the cement company from Delhi landfill site. This bold steps resulted in a win-win situation for all. Earlier, MCD used to pay 1,765 rupees per metric ton for lifting of RDF from the landfill sites. But now, MCD is saving huge cost and getting rid of the legacy waste, at the same time earning from it. On the other hand, the industry is obtaining fuel at the rate of just rupees 100 per metric ton as compared to rupees 6,000 that it paid for coal per metric ton. These steps resulted in expeditious bioremediation of waste accumulated at 3 Delhi landfill sites. In the 4 months From June to October 2022, a total of about 30 lakh metric ton of waste has been disposed of, compared to 50 lakh metric ton between 3 years from 2019 to May 2022. The monthly disposal average is now 6.52 lakh metric ton compared to average 1.4 lakh metric ton earlier. The aim is to level and finish garbage mounds of shame within next 18 months, and I'm sure that we will be able to do it. However, our bigger aim as city should be that no new garbage dump comes up and no fresh waste is added to the existing 3 sites. This can be possible only if we concurrently dispose our garbage generated daily in an environmentally sustainable manner. I am happy to share with you that we have taken many steps in this direction. Out of total 11,000 metric ton of waste being generated by Delhi every day, about 9,000 metric ton is being recycled and reused every day. We are hopeful that the balance 2,000 metric ton will also be processed soon. Friends, no enterprise can succeed without the proactive participation of its most important stake and shareholders. In this task, while the government MCD and its agencies are implementers of the decisions, the people are the stakeholders, shareholders, and indeed owners. It is here that your support as experts, peer leaders, influencers, and that of media is most critical. Your ownership of the issues and its promotion and the propagation will help the society at large be more conscious and effective in the implementation of the ways and means to address it. I appeal to you to come forward and become leading stakeholders in the task of making Delhi clean and healthy. At the end, I have no hesitation to say that the best hospitals that the Week magazine has chosen to honor after the survey are the most deserving ones. All of them have been doing stellar service to the country's healthcare administration. I congratulate them for winning these well-deserved awards and commend them further to do more. I wish you all the good health and in advance, Happy New Year. Thank you very much.
I would like to thank His Excellency for that speech, which and talking about things that we really don't see, we see every day, but never really, we sort of want to sweep it under the carpet like garbage really is. And I think that I think it really has motivated me, and I'm sure everybody, to sort of look at how much waste we produce, so that we can deal with this. So I would like to thank him for his time and his stirring speech to sort of bring us in and fight another war in some ways. And I would like to invite our resident editor, Mr. Prasannan, to come and give his memento to the Lieutenant Governor. Thank you, sir. Thank you for your time. And I know it's been a really busy schedule, and thank you again for taking out time and to sort of address us. I know that you have a pressing engagement apparently, and we don't want to keep you, and thank you so much again. I would now like to request Dr. Guleria, who really has been at the heart of fighting this battle against COVID-19, a battle that we remember, And I think he has really become, as Mr. Thomas said, the beloved doctor who everybody turned to. He was really the sort of calm in the middle of this swirling, rumors as well as uncertainty. So I would like to ask him to deliver his keynote address.
Thank you very much, and good morning to everyone. Dignitaries on the dais and my fellow colleagues who are there in the audience, members from the Week magazine, members from media, ladies and gentlemen. At the onset, let me take this opportunity to really congratulate the Week for the excellent work they're doing, especially as far as the health sector is concerned. They come out with this regular update on various issues on health, and they have this every year award ceremony, which is now going on for 19 years, to look at the best hospitals. And I think they do it in a very, a 360-degree manner, because not only do they have a feedback from the hospital, but they take a lot of information from GPs and others in terms of how the hospital is functioning, what is the referral system, and how is the quality being maintained. So I think it is something which is done in a very holistic manner, in a very unbiased and fair manner, and I'd like to take this opportunity to congratulate the Week for the activity that they're doing. Also, I'd like to take this opportunity to congratulate all the hospitals that have got the awards, and also those who didn't make it but strive to really reach that level, because that is what awards are all about. It's not only about getting the award, but also having that desire to work hard and try and get those awards next year. I was asked to really give a small talk on ensuring quality in healthcare, and I think this is a very, very important topic, because it's something that we really don't talk about as much as we should. And as the LG mentioned, we don't talk about waste management, and we have this huge sort of piles of waste lying, and we tend to ignore it even when we drive past it so many times a day. So that, I think, is similar to how do we look at ensuring quality in healthcare as we move forward. Now, if you look at what the WHO says that almost 5 to 8 million people die every year in low and middle income countries due to poor health care. That's a huge number, and that is something that is preventable. And I think this is something that we need to keep in mind, that these are the number of deaths that can be prevented if we were just to improve the quality of health care that we are able to provide. Even when we talk of universal health care, that seems is the mission that we have, it cannot be achieved without attention being given to quality of care. And the most important thing is in all settings. Quality of care is easier to do when we talk of a tertiary care hospital, a high-end hospital. But unless we are able to have quality of care in areas where the ecosystem is fragile, where there is more vulnerability, we will not be able to ensure quality in healthcare as we would like it to be. And I think that is something that we need to understand, that when we're talking of ensuring quality in healthcare, it has to be across the board, right from a primary health level up to a tertiary hospital. But what do we mean by quality of healthcare? We talk about it, we say it's a huge problem, but conceptually and from the operational point of view, if you talk to people, you could talk to policymakers, you could talk to health administration people, you could talk to doctors, they are not very clear as to what it really means. It's at times conceptually and operationally a vague term as to how do we achieve quality of healthcare. Does it mean the hospital has to be more clean? Does it mean that we have to have better facilities? Or does it mean that we have to decrease our waiting time? I think what we really talk when we talk of quality as far as healthcare is concerned is ensuring effective, safe, people-centric, timely, equitable, and a culture of excellence as far as hospitals are concerned. and this should be linked to an assured outcome. Now, these are very, very difficult and challenging things to achieve. You want to have an effective system which is safe, because that is something which is linked to quality care. It should be people-centric, patient-centric. After all, the hospital is meant for patients rather than the doctors themselves. The doctors would not exist if there were no patients. And it has to be timely and equitable across all socioeconomic status. I personally feel also that it has to be a continuous process. There is no way that quality of healthcare finishes today and then you do nothing. It has to be something which has to move on. It has to be linked with knowledge generation, and it has to be linked with lessons that we've learned. And I think if you look back at the last 2.5, 3 years, we did learn a lot of lessons as far as the pandemic was concerned. It really shook the healthcare system in terms of providing quality of care when there was a huge surge in the number of cases. There was uncertainty when you're dealing with the new virus. There was uncertainty in terms of infection control practices. There was uncertainty in terms of treatment to give. And there was uncertainty in terms of the need of medication and other equipment that was required. Should we focus on buying more ventilators? Should we focus on more oxygen plants? Should we focus on keeping more drugs like remdesivir or steroids? Or should we look at what the data says? Because it was an evolving situation. And I think most hospitals found that they were not able to ensure the quality of healthcare that they would have liked to do. And those are the lessons that we need to really look at as we move forward. How can we ensure quality of healthcare post the pandemic and sort of learn from the lessons that we've learned in the past? Also, I think it's important to remember that a large number of mortality or deaths occur because we're not able to ensure quality as far as healthcare is concerned. If you look at data from the US, the third leading cause of death in the US are medical errors. And if we were to look at data from India, we don't have any data from India, but I'm sure the number is going to be much larger than what we see in the US. And we tend to again ignore this, push it under the carpet, but we have so many instances where because of medical errors, we have more complications and higher death rates. It happens in the US. We know of a famous case of surgery being done on the wrong side of a patient whose name was mixed up because it was an Indian name. I know of a person who died because of wrong blood group being given in the US for a surgery. So we need to develop processes, and this is all part of quality of healthcare. A lot of people feel that the quality of healthcare over time has deteriorated. And I think we need to generate data to see whether we're able to maintain those high standards with increasing demand as far as the healthcare system is concerned. In most hospitals, especially in the government sector, we see long queues, we see poor service delivery systems, there is insufficient facilities or infrastructure, and there's a huge demand as far as doctors are concerned, the healthcare facility is concerned, sometimes there's a shortage of beds. We need to develop strategies of how can we overcome that. Unfortunately, in many areas, there is a reluctance to develop and utilize quality improvement-based strategies. Sometimes we feel that, if you talk to people, they feel that this is not a priority as far as we are concerned. And I feel this is something that we need to really put right up front in terms of a huge priority for all hospitals, that quality has to be ensured. And I personally feel that this is going to become more and more challenging in the coming decade. We are all living through a revolution. We're living through what is known as the fourth industrial revolution, where medicine is going to change so dramatically that sometimes it's even hard to imagine what's going to happen as far as doctors of the future are concerned. Artificial intelligence has come in a big way. We are talking of AI-based X-rays being interpreted, pathology reports or slides being interpreted using artificial intelligence, even skin lesions. You could take a picture of your skin lesion, send it to an AI-based software, and it could diagnose what the skin lesion is and even say what is the likely diagnosis. This will all become part of the health sector. We will have the Internet of Things, wearable devices. Many people still have their Apple watches and they can see their ECG, they can tell you whether you have an arrhythmia or atrial fibrillation. This will become part of standard healthcare, that you would have wearable devices which will be able to monitor a large part of your health. You would have virtual reality coming in a big way, and a big data analysis will also be there. 3D printing will be there in terms of health. How do we get all of this into health and still ensure quality of healthcare? That is the challenge that we're going to see in the next decade. And I think we need to start working aggressively so that we're able to maintain those prime principles that I mentioned: equity, effectiveness as far as healthcare is concerned. So what is the way forward? And I would like to just propose a few things which I think is the way forward as far as ensuring quality in healthcare is concerned. One is, I think each hospital has to develop a holistic continuous model. One size fits all doesn't work. The government sector has its own challenges, corporate sector has its own challenges, metros have their own challenges, state hospitals, district hospitals have their own challenges. So a holistic continuous model needs to be developed which looks at the issues that are there in each area. And we need to develop a PDCA model, that is plan, do, check, and action. So we need to really work on all of this in terms of ensuring quality as far as healthcare is concerned. Hospitals need to develop a process map so that they are able to work in that direction. And of course, identify service gaps which exist and see how they can correct them. But I also feel there is a huge need to accept, adapt, and adopt information technology. IT is there to help, and somehow the health sector has been reluctant to really take in IT the way other sectors have taken it. And if we are able to use IT in a big way, a lot of quality in healthcare can be ensured. There has to be SOPs as far as each action is concerned. We always talk of checklists, and I think we need more and more checklists to make sure that we don't make mistakes, whether it be an outpatient, whether it be the emergency, inpatient, or in the operation theaters. And of course, the most important thing is to increase awareness among policymakers, among healthcare professionals, among administrators, that the importance of quality of healthcare cannot be undermined, and I think that is something that we need to do. I also feel we need to develop a measurement matrix, collect the data, calculate it, give it weightage, and develop a matrix as to how do we develop solutions for the future. And of course, there has to be appraisal, feedback, look at the mortality, look at your readmission rates, what is the hospital infection rates. Most hospitals are reluctant to give out their infection rate data because they feel it may have a negative impact on the hospital. But this is something which will help you to improve. And I think we must really look at our hospital infection rate data and see what are the corrective measures that we can take. What is the surgery time? Is there a huge wait list between date for surgery and the surgery time, or date for patient getting admitted and getting operated? How can that be decreased? All of these are part of quality as far as healthcare is concerned. The emergency waiting, very, very important thing. People stand and wait in the emergency for a long time. How can we decrease that? I remember some time back in the All Institute of Medical Sciences, a study was done which said that if a person came with chest discomfort, it was taking almost 25 minutes between reporting to the emergency and getting an ECG done. But with quality control measures, with inputs and SOPs in place, that has come down to less than 9 minutes. So it is possible that you can develop SOPs in places, both in the government sector and in the private sector, to see how you can really work on ensuring quality as far as healthcare is concerned. It's a challenging subject. I know it's going to be something that we will all need to work together, but I'm confident that as we move forward and as we get inputs and support from organizations like the Week, which really look at all of this, hospitals will start giving more and more attention to maintaining good quality as far as healthcare is concerned. So finally, I'd just like to say that in my personal opinion, this is something that we must really put right on top of our priority and develop strategies in terms of how do we ensure a continuum as far as quality in healthcare is concerned, and how is it more specific to our hospital, our center, and our area. If we are able to do that, we will save lives, we will decrease the load on the patients, and we will improve the quality of care that we provide to our patients. Thank you very much.
Thank you, Dr. Guleria, for in a way asking us to strive harder and make things better. I would like to now request Dr. Guleria to please hand out the next batch of awards, please. These awards are the best multi-speciality hospitals city-wise. The best multi-speciality hospital. Okay. The best multi-speciality hospital, Hyderabad, goes to Apollo Health City.
Audio Jungle.
Best multi-speciality hospital, Thiruvananthapuram, goes to KIMS Health. Best multi-speciality hospital, Chandigarh, Fortis Hospital, Mohali. Best multi-speciality hospital, Ahmedabad, Zydus Hospitals.
Audio Jungle.
Best multi-speciality hospital, Bhubaneswar, Apollo Hospitals. Multi-speciality hospital, Nagpur, Alexis Multi-Speciality Hospital. Best multi-speciality hospital, Jaipur, Santokha Dulla
Audio Jungle.
Memorial Hospital. Best multi-speciality hospital, Lucknow, Apollo Medics Super Speciality Hospital. I'm going to call out the best multi-speciality hospital in a metro city. Medanta wasn't there earlier, so I'm just going to ask them to come in. I believe there's a representative here right now. The best multi-speciality hospital, Delhi NCR. Medanta, the Medicity, Gurugram. There were also there were 4 other awards for 4 other hospitals who couldn't be there, but I'm just going to call them out. The best multi-speciality hospital, Pune, goes to Dinanath Mangeshkar Hospital and Research Center. Best multi-speciality hospital, Indore, goes to Choit Ram Hospital and Research Center. Best Multi-Speciality Hospital, Coimbatore, goes to Kovai Medical Center and Hospital. The Best Multi-Speciality Hospital, Kochi, Amrita Institute of Medical Sciences. Thank you, Dr. Guleria, for giving out the awards and for your address. I would ask Stanley Thomas, Senior News Editor, to please hand over a memento to Dr. Guleria. The Honorable Minister for Earth, Independent Charge, Earth Sciences, was supposed to address us, but unfortunately, because of Gujarat, he was called away and he was not going to be here. But it's now time to actually have a conversation with doctors and talk about how technology and how is going to help us, and that's the new frontier we are going to have to tackle. So I would like to request my colleague Pooja Biraiya to please come in and moderate the panel discussion, and I would please like all the panelists to come onto the stage, please. Thank you.
Very good morning, everyone. So we will now begin with a panel discussion, and for that, I would like to invite the panelists onto the stage, please. Let me begin with Dr. Anupam Sibal, Group Medical Director, Apollo Hospitals Group, India. And let me introduce Dr. Sibal first. Dr. Sibal comes with more than 20 years of experience with a proven track record in high visibility roles, such as President, Global Association of Physicians of Indian Origin, Senior Consultant Pediatric Gastroenterologist and Hepatologist at Indraprasth Apollo Hospitals in Delhi. He has also served as a member of the leadership team credited with establishing Apollo Hospitals Group as the largest healthcare provider in India and the region. He created a global collaboration to bring together 1.4 million physicians of Indian origin from 49 countries on one platform. He also championed the patient safety movement in India and is well known as an international expert in pediatric gastroenterology and hepatology. Welcome, Dr. Sibal. Kindly join us onto the stage. Also, Dr. Sibal is a very well-known author and a speaker. Welcome, sir. We now have Dr. Devleena Chakravarti, Managing Director of Artemis Hospitals. Dr. Devleena started her career in 1993 as a radiologist after being trained at Mumbai University. Further, she undertook fellowship and preceptorship programs from the University of Berlin in Germany, UCLA in Los Angeles, and Birmingham. Before joining Artemis in the year 2007, Dr. Devleena Chakravarti worked as a senior faculty and program director in radiology in some of the most reputed hospitals in Delhi. She garners a belief that private hospitals are capable of making profits without resorting to profiteering. She accords high importance to the safety of her patients, quality medical outcomes, and infection control. She is driven by the motto of personalized tertiary care coupled with service excellence. The key professional memberships of Dr. Devleena Chakravarti include the Indian Neurology Association and the Indian Radiology and Imaging Association, among many, many others. Welcome, Doctor. Right, we now have Dr. Santosh Shetty among us, Executive Director and CEO at Kokilaben Dhirubhai Ambani Hospital in Mumbai. Welcome, sir. Dr. Shetty completed his MBBS from Mumbai University and MHA from Tata Institute of Social Sciences. In addition, he has aced the Advanced Management Program from NUS Singapore and has qualified as the NABH assessor. He has been involved with hospital operations for the last 20 years, that is 2 decades now, in various senior leadership positions, including roles as Head of Medical Services at Wockhardt Hospital in Mumbai, CEO at Breach Candy Hospital, among others. At present, he is responsible for the operations at the hospital as the foremost leader, and he is also driving the expansion initiatives of the group. Welcome again, sir. Right. We now have with us Dr. Anand R. He is the head quality at Manipal Health Enterprises Private Limited. Welcome onto the stage, sir. He is a pulmonologist by qualification, and at present he oversees various quality improvement and patient safety initiatives with the aim of enhancing the quality of patient care. The focus has been on ensuring that patient safety is accorded topmost priority. He is zealous about quality in healthcare and in particular accreditation systems. He has been involved in the implementation of quality management system in his organization. He has been involved with NABH, which is the apex healthcare accreditation body of India, almost since its inception, and has served in various committees of NABH. He has played a key role in developing various NABH standards and designing training programs for it as well. He has served as a resource person for NABH for various training programs. Welcome again, sir. Right. Hello? Okay. So we are now beginning the panel discussion. I think we will begin on the note that every patient deserves the right treatment at the hands of the right clinicians at the right time for the right outcomes. And facilitating all of this are hospitals that deliver quality healthcare without compromising on the standards. So beginning with you, Dr. Shetty, we will start with you. Kokilabhen Ambani Hospital, as we all know, is a global institution of excellence, and technology is at the heart of your hospital, at the heart of everything you do. In fact, for the story that we did in the Best Hospitals issue, we visited your various rehabilitation programs in neurology. So tell us, how do you ensure that technology comes first when it comes to promoting quality healthcare for patients?
A very good morning, and thank you for having me as part of this panel. So as an institution, we've always had a very strong focus on technology, because we believe that technology is a key enabler to deliver quality outcomes, enabler to improve patient safety, and an enabler to reduce the potential or possibility of error. So when we look at technology, we look at opportunities in technology which will help us to improve diagnosis, get to a diagnosis early, improve treatment, reduce risk of complications, and improve the quality of life for the patient. I think these are some of the key parameters that we do when we look at technology. You mentioned about robotics, so when rehab robotics. So when we set up our rehab department, it was a one-of-a-kind specialty. It was about filling up a need gap, and along with filling up a need gap, we said let's invest in technology which will help patients. So when we look at patients with spine injuries, with stroke, with brain hemorrhages, these are patients who struggle to get back into an active lifestyle. So through rehab robotics, we were actually able to get them vertical, which is the first thing. Patients want to get out of bed, patients want to stand. So these kind of technologies with exoskeletons, which actually help patients get back to their normal lifestyle, I think contribute a very big thing in terms of patient quality as well as patient satisfaction. Yeah. Similarly, technologies like rehab robotics and rehab surgery. When you look at robotic surgery like Intuitive, I mean, these are technologies which not just help in reducing complications, but they also protect the reproductive health of the patient. So technologies which improve quality of life, I think that has been a very, very big key decision point for us when we've gone for technology. So overall, we look at it as an enabler, but at the end of it, I would like to say that it has to be part of an integrated program. Technology by itself means nothing unless you have the whole support infrastructure, the people, and a very strong desire and passion to drive it.
Right, absolutely. I agree with that. Technology as the enabler. Dr. Sibyl, let me bring you in here. Technology as the enabler. Also, at the same time, how do we ensure that along with technology, in order to provide quality healthcare, we also keep patient safety on the topmost, as the topmost priorities in our minds. So how do you ensure at Apollo that all these three are, go hand in hand and at par?
Well, good morning, friends. Thank you very much for this invitation. And, we have all of us have a lot of respect for the Week magazine. And, your tagline is journalism with a human touch. And everyone in healthcare attaches a lot of importance to the human touch, because technology will keep changing and everyone can buy technology. But while we become more and more high tech, it's very important to remain high touch, because at the end of the day, it's the healthcare provider talking to the patient, to the family, that makes a huge difference. Now, every life is precious, life is priceless, so patient safety really needs to be inbuilt into the culture of the organization. And one way of doing this, and there can be many ways, is accreditation. So we started talking about accreditation because we wanted to develop a culture of continuous quality improvement and patient safety. So in 2003, we examined all the healthcare accreditation systems in the world and finally zeroed in on Joint Commission, which is based in Chicago. Our hospital in Delhi became the first in India, and it was only the 6th hospital in Asia at that point in time to get accredited. Now, what does accreditation do? And we've got 8 JCI accredited hospitals. We have 32 NABH accredited hospitals. So this is a journey, over the last 17 years. And what it does is, and you talked about every patient getting the right treatment by the right clinician with the right outcome. Now, when we talk about these rights, there are 2 other rights that are very important, which is the clinician should have the right experience and expertise. Now, that is something that accreditation ensures, because there is a whole lot of focus on staffing. For example, should every cardiothoracic surgeon be allowed to operate on a baby? And the answer is no, unless he's a trained pediatric cardiothoracic surgeon. Or should every GI surgeon be allowed to do a right hepatectomy? And the answer is no, unless he has experience in that space. So this is just one example of staffing. JCI currently in the 7th edition has 13 chapters, a huge focus on clinical, but also in terms of management, in keeping the facility safe, in governance, and it takes up everything right to the level of the director. So if there's a contract and you are outsourcing something, who has the contract oversight? How do you know that the contractor is delivering what they had agreed to? Do you actually make unannounced visits and see that they are complying or not? And there are 282 standards and 1,182 measurable elements. So there is a lot that an organization learns, and based on our experience, we've seen our infection indices get better. We've seen our average length of stay become less. We've seen patient falls decrease. We've seen communication errors become much less. We've seen surgical practice improve because you have a safe surgery checklist, you do a timeout. Some of the things that Professor Guleria alluded to, where you can get the name wrong. And do you have the right instrument? Sometimes you go in and the wrong X-ray has been put up there, or MRI in the OT. So all that goes away with better communication through international patient safety goals. Yeah. But what is very, very important is that there is this culture that comes in about constantly improving. What is best practice today will not be best practice the next year. Right. So you have to develop an annual plan. Everybody develops an annual operating plan. Everybody develops a budget. But you also have to develop an annual plan for quality improvement that actually needs to go to the board and get approved by the board. Right. How do you prepare for something going wrong? Fire. Now, we've heard of fire incidents in hospitals. How do you prepare? Right. How do you evacuate? In terms of epidemic preparedness, disaster, what if there's an earthquake? What if there's a bomb blast? How do you manage? How do you evacuate? And I think that really helped us in COVID as well, because there was a plan that we had in place. Our first experience with managing an epidemic was with swine flu in 2009, so there was a system in place. Then came MERS in 2012, and the learning and what is expected in accreditation helped us prepare, I think, quickly for COVID. Of course, the enormity no one had imagined, but at least the learning and the fact that we had a system in place helped us to scale up and develop our red book, change our protocols. In fact, we changed our clinical protocols 52 times, including twice in 1 week when the trial from UK suggested that steroids should be given.
Right. So planning, preparation, and communication, I think that's the key word. Those are the key words. Right. Dr. Chakravarti, coming to you, how was it at Artemis Hospitals? How did you tackle, these kind of, in the last 2 years of the pandemic? And how did, as a leader, how significant was it to really communicate, right to the last person standing in the hospital? Yeah.
Good morning, and thank you for this opportunity. And it clearly shows traction the Week magazine has. We have come from all across the country to be here today, and I thank you for this opportunity to speak to this August gathering here. So in the last 2 years, and maybe more than that, when COVID struck the country, we were all at sea. And rightly so, because none of us knew what was happening, what was the nature of this virus, and how were we going to tackle it. Luckily for us, Artemis Hospital, which started in 2007, got its JCI accreditation in 2010. So like Dr. Sibal mentioned, when you get an accreditation, it kind of allows you into systems and protocols and running SOPs and a certain way of thinking. It inculcates a discipline, a culture, and somehow prepares you to kind of be ready for any kind of untoward threats, is what I would like to say. So, and we at Artemis, we believe that getting accreditation, whether it is a JCI, NABH, NABL, is not a certificate to be put on the wall, but it was always a work in progress. And that helped us greatly, because by then we had created a culture of safety, a culture of ownership, a culture of communication across all lines. And that helped us to get together and fight this pandemic when it stuck. So when it first came, and all of us huddled together to look at domestic, international protocols, talking to peer groups, one thing that I told my team was that we are very fortunate to be in the middle of a chaos like this. We see the Indian Army always at the border. We see them fighting for the country. So today we have an opportunity to do the same. And people will remember these medical professionals for years to come for what we did or did not do at this point of time. And I think this echoed very strongly, not across just hospitals, across people, across all lines, where people came to help, all the hospitals with resources, with meals, with oxygen. And our basic discipline, like our army, our military, they're able to perform because of the discipline. And we were kind of in that zone already. Every time we looked at a new variant, we created an SOP, the treatment protocol, we measured the outcomes, we measured the mortality, and changed before it was too late. So it is very, very important, like all of my peers have mentioned here, that we must have a system where we know what we are doing and measure our outcomes to be able to manage it. Chaos happened once, and we do not know whether it will strike us again or not. But if we have our house in order, we will be in a position to handle most of it. And I'll take a minute here because, quality of healthcare is very close to my heart. And when we talk about quality, we talk about accreditation, we talk about, government hospitals, private hospitals, tertiary hospitals. But like Dr. Guleria mentioned, as a country, we will be able to, achieve quality of healthcare if we are able to make healthcare accessible and affordable. Now, both of this is, it's not like one size fits all. When we talk about accessibility, how does a person staying 100 kilometers away from you have an access to you? We have to think in those lines. Digitization, IT, all this kind of intervention has greatly helped us in accessing people. And today we have to think beyond our own islands of excellence, own systems and protocol. We have to join hands, the public-private sector. We have to join hands with other corporates. We saw that happening during COVID times. They were more than happy to support us. So we have to join hands with corporates, their CSR fund, to create a pan-India system of quality healthcare. And when we talk about quality of healthcare, we must talk about trained medical professional, accessibility to these medical professional, and affordability. And technology, IT, SOPs, protocol, accreditation, and most importantly, the desire to be the great provider in healthcare is going to take us forward. Thank you very much.
So profound thought there, Dr. Chakravarti. Dr. Anand, let me ask you, we've been talking about accreditations a lot because that really kind of, gives us a proof that yes, it stands for quality, right? So tell us, because you've been involved with a lot of quality care initiatives, tell us what are the parameters by which an institution is certified for quality and accredited thereby?
Good morning. At the outset, I thank the Week magazine for having me over as a panelist. So let me borrow ideas, if I may, because we as a country are very good with borrowing ideas and then innovating it for our context, because that's the most important part. So let me begin by how I would put it as altogether. Safe, patient-centric quality care using effective and efficient resources with a strong leadership. Now let me try and break each one of these components because that's what accreditation is all about. Dr. Sibal spoke about patient safety. One of the cornerstones of any accreditation system for any hospital to go for accreditation is that focus on patient safety. Let us be very, very clear. It may be as simple as preventing a patient fall to as complex as maybe dealing with fire hazards, dealing with bomb threats, so on and so forth. But that is the cornerstone. And we also need to understand that when we say patient safety, we also include the staff safety. Although the emphasis on patient, 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 I'll take what Stanley said in the initial thing, we do not forget the doctors, we do not forget the healthcare professionals who are a part of that team. So what is patient-centric, the next part? Every accreditation standard, be it NABH, be it JCI, any other accreditation standard, has an emphasis on what we call as clinical care. And when I say clinical care, it includes the whole gamut of from the time the patient enters the hospital till the patient gets discharged. So it is in a way, rather than saying from the cradle to the grave, I put it as from entry to exit in a different manner. As simple as registration process, how do they communicate, how are discharge instructions given, how are medications given, all that comes under the gamut of what I would call as patient-centric. If I move to the next important component, the whole thing, what is quality? Dr. Gulera gave us a very good definition of what quality is all about. Dr. Sibal also spoke about, I just said, right care to the right patient at the right time, and if I may take what Dr. Chakra said, at the right cost. In simple words, that is what quality is all about. So any accreditation standard will therefore focus on the components of how are we getting the process in place, because all my esteemed panelists already said, it's important to have those protocols, it's important to have those processes in place. So when you say quality, how do you put them in place? How do you measure them? It's not that sufficient if you say that, oh, I have put a wonderful system, we need to measure it. We can't stop at measuring, we need to improve on it. And then we can't just stop at improving, we need to ensure that we actually made an improvement. So that's what I mean by quality. Effective and efficient use of resources, be it human resources, be it the material resources, be it finance, be it technology, everything has to be used in a proper manner. So every accreditation standard, therefore, has a focus on what are all the support services, what could get included in that. And all this revolves around the leadership, but at the end of the day, it is the leadership which still drives all these initiatives. It requires a strong leadership to ensure that there is a culture which is created, to ensure that falls are not zero, to ensure that surgical site infections are not zero, to ensure that ventilator-associated pneumonias are not zero. In case you're wondering as to why I keep saying that, because when we go as NABH, SSR, for the matter for any accreditation system to hospitals, These are the numbers that are given to us. And many a times I've said it aloud, but definitely in my mind I've said, are we really a hospital? But if we keep denying and stating that there is no issue, there is no harm which is going on, I think we are living in a utopian world, and that's the reason as to why that leadership has to create that culture where the staff are empowered to speak about those issues, and that for me is the bedrock on which the entire accreditation system rests. Thank you.
Right, thank you, sir. And that, that prompts me to recall an interview, Dr. Chakravarti, not an interview, I think a video that you had shared with your staff, with your support staff, in which it was a very heartfelt, short video in which Dr. Chakravarti spoke to the nurses in her hospital. I think it was pre-COVID time. And Doctor, tell us how did, because I think communication is the essence of leadership, since we are talking about leadership here. Tell us, how did you really go about doing that, and what was the outcome, and how did it improve? Yeah.
I was not aware that you saw that video, but yeah. So, it has been my philosophy from the time I took over as an administrator, a very open door policy. And I feel the essence of a good leader is that he or she must have his ear to the ground to understand what is happening. And only then you get the trust of the people, they communicate with you, and you create an environment of ownership. When people speak to me, I listen. When I speak to them, they listen. So yes, our nursing staff, the video which you are talking about, the nursing staff were right at the forefront. They were like the first line warriors in any kind of war. And in our hospital, we have always acknowledged the fact that our nurses, our paramedics are second to none, So in that video, I was, yes, trying to motivate them, but that was just an isolated COVID video. But as a culture, what we do is we are constantly upskilling our nurses, our paramedics, reviewing, understanding their aspirations, and allowing them a vertical or a lateral move, If you have an environment, the doctors are right on top, and they are almost always heard. But if you start hearing the second and the third tier of your healthcare professional, it leads to a very, very comprehensive healthcare delivery system. And it empowers them like it's unbelievable. And it brings out issues which affects patient quality, patient safety, because now they feel empowered. They do not think that they're here only to take orders from their senior bosses, but they think they are at par and they are part of a decision-making process. So very often, and I'm going to give you an example, in one of our liver transplant committees, and when everything went off and the donor and everybody asked, there is no coercion and you are giving it on your own, and she agreed to her, I don't remember, I think it was the husband, and even the government representatives over there who grilled the donor, and they agreed. And at the end of it, the next day, the nurse, the transplant nurse, walks up to my office, because firstly she knows she can talk to me, and she can raise a red flag when it is important. And she comes and tells me the donor is under coercion. She has 2 small children, and she does not want to, that's her choice. It could be her husband, but she was under coercion. So and she picked it up, and she had the guts to walk up and bring it up. So when we talk about ethics and safety, we have to make every single member of our community, or when I say community, is a hospital is what I'm talking about, empowered to be that torch bearer and bring it to the forefront. And that's the reason I communicate, I listen, and I implement what they say. So they have faith in the people and the management, and they feel that they'll be heard, and their suggestions will be implemented.
It's so important for the communication channel to keep going. I think that works great. Dr. Shetty, I would also, want our listeners to know, because the Kokilaben Ambani, at Kokilaben Ambani technology, your technology is, at par with the best in the world. So tell us, how do you ensure that quality of care remains with international standards in India? And have we reached there, and how are we progressing, if not yet? So.
Thank you. So if you talk of quality, and I think Dr. Guleria touched on multiple aspects of quality, this is still in a very evolving stage right now. We are still at a stage where hospitals are wary about putting out data, putting out information, worried about whether, how will it be perceived by the community or by other peers. So it's very important for us to get out of that stage. So to get out and put out that data, share it amongst our peers, learn from each other. I think one thing that I still feel is lacking in the healthcare sector is collaboration between various players. It's important to learn from each other. I'm sure there could be some best practices in another hospital which we could learn from, and we could have some practices which somebody else can learn from, because unless we compare ourselves to our peers, there's no way that we can keep improving. And that is the difference between some of the accreditation standards in the Western world vis-a-vis us, that we've still not been able to get a forum where we share data, we talk to each other, because that is the only way that we can get to improving. If you talk of technology and how technology is affecting quality or improving, and again I'd like to borrow a line from what Dr. Guleria mentioned about things like digital pathology. We've invested in digital pathology, and you can see the difference vis-a-vis a histopathologist peering into a microscope and looking onto a digitized screen with an ability to magnify images, which is backed by artificial intelligence, which actually points out that these are the areas that you need to look at, that you need to focus at. So obviously these will help in diagnosis, these will help in treatment. So technology from that point of view will play a very, very critical role. The other area where technology can play a role, which also we touched about, is how do we use technology to make healthcare accessible and affordable. That is again a very, very important element. And at our hospital we saw that we used to have many patients coming for surgery, but when it comes to radiation and chemo, they would not really stay back, because staying in Mumbai for 4 to 6 weeks can be more expensive than the cost of the treatment. So we did a survey in the state of Maharashtra, and we identified about 18 districts which didn't have facilities for radiation and chemo. And we set up small centers there, daycare centers, which only do radiation and chemo. And we built in technology in such a way that all the plans would be made in Mumbai, and then they would be sent to Akola or Sholapur or Gondia. So while we had a junior radiation oncologist there, he had the benefit of getting all the technical inputs from the head of the department. So all the plans would go there, and patients in these districts which had no access to a linear accelerator would get care on par with what was being provided at Kokilaben through this technology. Not only that, all these patients were covered under the state schemes, so as a result of which 90 to 95% of patients actually did not have to pay anything out of pocket. So this was again a scenario where we've used technology to make healthcare more accessible and more affordable. But just to summarize, I think we are in the right direction, but we still have a long way to go. The newer technologies that are coming in are extremely exciting. I mean, we talked about wearables, we talked about IoT, we talked about artificial intelligence, to have monitors which, based on data which is being captured in the ICU, actually be able to predict that this is a patient who's going to get a stroke in the next hour, so you can intervene now. I mean, these are some of the things that, the potential of AI has, and I think we are all working in that direction. The next phase of 5G, which is coming in, we will again give a huge fillip, because one can actually do remote surgery. A surgeon sitting somewhere can actually do surgery in another city. I mean, so those are the kind of potential that exists as far as technologies go. The whole point will have to be, how do we make it more accessible and more affordable?
To make it more accessible and more affordable. Right, Dr. Sibal, taking this thought forward, Apollo has also, spoken much more about telemedicine. Basically, you all have emphasized on the role of telemedicine a lot during COVID and also now going forward. How do you make sure that, as Dr. Shetty said, healthcare has to be accessible and affordable alongside, using technology to make it so? So what has been the role played by Apollo in this regard, please?
Well, Gandhiji had told us many, many years the future of India lies in her villages. We have 625,000 villages. So how many radiologists do we have? Less than 50,000. So will every village ever have a radiologist? The answer is no. We are going to have to be innovative, and I think we understand frugal innovation well, and that really is where the salvation lies. We have 1 million ashas. We have nurses who need to be empowered and function beyond their current role as nurse practitioners, as nurse managers. We need what is done by a doctor to be done by someone else if that level of expertise is not needed. We need to bring in automation. We've recently done a study where we used a machine learning based algorithm to look at chest x-rays and found that ML picked up chest lesions which were comparable to a panel of 4 radiologists. It's just one baby step, but I think we need to be able to innovate like that. You are in a small town and someone has a bleed, intracranial bleed.
Yes.
Now we don't know what exactly is going on.
Right.
There might be access to a CT, but you might not get a radiologist. So we should be able to use WhatsApp, and again based on ML, be able to predict when someone comes in with that problem, what should be the treatment. For example, if someone comes in with a stroke and there is a thrombus, then that patient should be thrombolized in a small nursing home 400 kilometers from a metro. And that can be picked up because there'll be a CT, and that image needs to be interpreted because you don't have someone to interpret that. Also, what is happening now is that the patient wants one instant care, they want care at home, and they want it to be super efficient. Now, many of us have been looking at telemedicine. In fact, Mr. Clinton had inaugurated our telemedicine program way back in 2003. And we've done some interesting work in the Himalayas, in Kelong, Kaza, at 12,000 feet providing care to, urban healthcare centers in Andhra Pradesh, to Aushadhis in Jharkhand and so on. But we had touched 13 million lives. And then came COVID, and during COVID we did 3 million telemedicine consults. So basically, patients today are more, there is a level of acceptance that we didn't have, and COVID made that happen. And I think there is a huge amount of value that brings in. I think the government of India was very, very proactive, issued the telemedicine guidelines in a matter of weeks that really helped things. Why should someone have to come and see a specialist in Delhi, come from, for example, somewhere in say, Vaishali in Bihar, to see a rheumatologist? All that the rheumatologist in his second or third consult is going to look at some blood parameters, ask a few questions, will in all probability not need to examine, and will change the immunosuppressant medication. Why should someone spend 2 days by train coming and going? And in India, nobody comes alone, so there are always 2 or 3 people who come along. And then they're going to have to stay somewhere in Delhi, spend a lot of money, loss of wages, the inconvenience. Now you're in one part of Delhi, it takes 2 hours to come to another part of Delhi. Why do you need to do that if a physical examination is not needed, or you don't need to do an intervention? So clearly, telemedicine is really going to be very important. The other thing we discovered was with digital pathology. So there are 13 subspecializations in pathology, in histopathology today. So if you have, for example, a rare muscle disorder, honestly, there will be only a handful of pathologists who specialize in muscle pathology in the country. So what we did was that we have the Philips platform on digital pathology. So we credentialed our 83 pathologists in 13 subspecialties. So now we know if it's a renal pathology, this is someone who's had 2 kidney transplants and we are concerned about chronic rejection. This biopsy needs to be uplinked, and our clinician, our pathologist can see it on her screen at home and give an opinion. Similarly, EICUs. We have 2 very distinguished intensivists, Dr. Guleria, Dr. Mayank. How many intensivists does India have? But why do you need an intensivist in every hospital? We managed 100 beds through our eICU platform with 3 intensivists managing per shift across 18 hospitals. You can see everything real time. You can see their parameters. You have the lab reports in front of you. You have the ventilatory settings. You can do all that sitting in one area. So clearly we're going to have to use technology more effectively, and only then are we going to be able to reach out to 1.35 billion people. It is not going to be brick and mortar anymore, and it doesn't make sense. People should come into a hospital only for stuff for which they need to come into a hospital. If that condition can be managed as an outpatient, so should it be. If a patient needs to come in for a few hours, and you know, we had this strange thing with our insurance providers. You had to admit someone for reimbursement. Why? After many procedures, a patient can go home in 8 hours. All India Institute did a hip replacement daycare. We have a surgeon in Indore. He did it a few weeks later, sent the same patient, sent a young patient who needed a hip replacement after 9 hours. So why should someone with a total knee replacement hang in a hospital for 4 days, block beds? So the question is, we have 20,000 or so hospitals. It is expensive to build hospitals. It's expensive to maintain them, and it's expensive to keep them safe. What we need to do is serve those beds more effectively. I'll give you another example. If you get protocols and clinical pathways in, why should a patient after a bypass stay in hospital for 7 days? When you use minimal access cardiac surgery, now our average length of stay in Bangalore, where we do minimal access surgery, is 36 hours after a bypass surgery. So why should a patient have to spend an extra 4 days? So let's utilize the existing infrastructure better so that we are able to serve more patients, use technology so that we are able to reach out to more patients, and actually do this in a manner which is not only more cost effective, but it's also more convenient and comfortable for families and for patients.
Right. Yes, and I think in the area of pulmonology also, Dr. Anand, how do we ensure that technology can help in the quality of care and reduce timelines? As Dr. Sibyl said, it can reduce timelines, it can increase effectiveness, it can increase efficiency. So yeah, because there are chances of nosocomial infections also among children, and have these gone down with the coming out of technology and stuff? Yeah.
So I think I'll just begin with, I think, if you remember, the opening lines of The Tale of Two Cities begins with, "It was the best of times, it was the worst of times." So I think if you look at technology as to how it's going to make a difference in terms of quality of care that we provide, we are living in actually very exciting times. Artificial intelligence, machine learning is something that I think we are all very comfortable with. If we had asked the same words maybe 2 years ago, 3 years ago, people would keep wondering, what's wrong with these guys? What are they speaking about? Now there's a universal acceptance to these terms. So there is a universal acceptance to telemedicine. So again, if you look at the eICUs, which Dr. Sibyl spoke upon, what we did in Manipal, we took it a step forward. We tied up for the government hospitals. How do you make it accessible? How do you make it affordable? But that's the same point. At the end of the day, there is a certain expertise which is there. The infrastructure exists in public hospitals, but there isn't enough manpower. So how do you bridge this gap? That's where technology plays a huge gap. Nosocomial infections, again, something which all of us tend to sweep under the carpet. It's like what the Honorable Lieutenant Governor said in mean. It's like waste. Everybody knows it happens, but everybody denies it happens. We tend to look at reasons other than nosocomial. We say, no, it was probably there. This patient has those comorbidities. He or she is at a high risk and whatnot. We will justify everything, but we will not say this actually happened because we could have prevented it. So if you look at technology, there are various markers, there are various scoring systems which tell you as to what's happening. So if you build an artificial intelligence to your lab reports, you build into digitize your imaging, it starts giving you, look, here's a warning bell. Even before I as a consultant, pulmonologist or the intensivist or my resident even flags it, the system will flag you, doc, be alert, this patient had it. That does not mean that I immediately change. That's where the human component comes in. That's when we need to really critically appraise those reports. But at the end of the day, one of my favorite taglines to all my patients is, I will not treat the report, I will treat you. Because that's the most important thing that we as clinicians need to remember. And that's the same thing which happens with technology. So technology for me is going to flag it But at the end of the day, I need to make that decision. Am I going to step up the antibiotic now, or am I going to wait? Am I going to be changing strategy? Am I going to be doing additional investigation? That's how investigation, this technology plays a role. And the extremes of age, I take pediatrics and geriatric. Though you touched upon only pediatrics, I'll take both of them. Because India is now a country where the geriatric population is increasing rapidly with increasing life expectancy. So I think these are the most vulnerable, if I may use that phrase, when it comes to them. So it's all the more important that we are more compassionate, we are more judicious in how we use our investigation on them. And that is where this technology plays a key role. Thank you.
Right. And also, sir, quality as we know it comes at a cost. Dr. Chakravarti, would you like to throw a light on, once you said that, private hospitals are capable of making profits without resorting to profiteering. If you could throw a light on how and best can we balance quality healthcare without compromising on expenses.
Yeah, I'll come in a moment to your question. And before that, because I'm a radiologist and technology, and I think I missed the technology question. So I will quickly touch upon it because I think the health tech started in its biggest way in the field of radiology. And of course, today we have telemedicine, teleradiology, and say what you want. And I am a person who likes to push technology, be right up there with whatever latest is happening. But what pains me is if technology is not actually getting the cost of healthcare down, then we have a problem in hand. Like all outcomes, we have to measure the cost of healthcare when we are putting technology as a big player in all of this. Who's measuring that? And are we really understanding how the cost of healthcare is going down? Yes, I agree, length of stays are going down. Yes, I agree the patient can access us from far away. But today, for most of the technology, we are dependent on, we are importing that technology. So all our vendors today who are providing us with solutions we are actually importing it from them. And unless we start developing these technology in-house, like the Make in India program, and I'm not trying to pitch it as a political statement here, it will be a long, long time before actually technology brings down the cost of healthcare. Because today you use one AI, tomorrow they are going to get a revised version of an AI, and you have no choice but to buy that at a premium price and then pass on the price to your patients. So technology is a double-edged sword, and we as doctors and healthcare providers definitely must adopt it, but also must measure the outcomes. Today you're doing a robotic surgery. How much extra does the patient have to pay for a robotic surgery? He might be staying less for 2 days, but how much does the cost of surgery go up? So at the end of the day, when A plus B is equal to C, does the C make the right impact that all of us are trying to chase? And we have to be attuned to that final outcome to say, yes, today we have made that change. Talking about quality in healthcare, I think there is no price that you have to pay if you embrace quality. When you have that quality, your price of delivering healthcare goes down automatically. If you embrace that quality and you have the best infection control, and I'm proud to say, we publish all our infection control. We are a listed company. We publish all our infection control reports to the board, which is available in the public domain. When you have less of nosocomial infection, patient stay is lesser, less expense on drugs and consumables. Just an example, your efficiency goes up and your cost of delivering healthcare goes down. People might be surprised that coming in from a private, I'm perpetually talking about cost. Because end of the day, all of us are doctors here. And I always believe profits can be made without profiteering, which you said. Because I am an alumni of Lady Harding Medical College, Delhi. And I always say, what has been taught in your medical college stays true till you stop practicing. So treat every patient like your family. Do not over-investigate. See how can optimize your cost and look at outcomes. Yes, add your technology, add your soft skills to make his or her life more comfortable. Once you have the faith of your patient, the moment you become a word of mouth hospital, it does not matter how big or large or what you are. People will come back to you for a second opinion. People will believe in you. And you will earn from the volume. So you don't have to, you will still make profits without profiteering if your basics are right. And you are perpetually working to ensure you're doing the right thing for the patient. You are keeping his costs down. You are doing the right thing for your employees. I mean, that's what we have all been taught as medical graduates. And the moment that becomes a culture, and your 2,000 or 5,000 or 15,000 employee just work towards that one goal, I promise you, profits will happen. And this divide between public and private will go. People will see you as a credible healthcare provider, and they're not going to ask you, are you private or public, because they know what you do is right. So you will make profits. So you don't have to be profiteering. It's what I have to say.
Pooja, I just want to comment on
Yes.
this thing, this question, that patient safety, quality, accreditation is expensive. I think we should change the narrative. This question is actually outdated. All of us fly. When we take a plane, you assume that the engine has been serviced. Right. The plane is airworthy. The pilot, both the pilot and the co-pilot are fit. The seat belts will work. There'll be the right amount of pressure in the tires, and there'll be the right amount of aviation fuel. You'll be surprised, there was some confusion about pounds versus kilograms, and a crash happened because the information wasn't right. But of course, aviation has, over the last 3 or 4 decades, really become very safe. So the question here is, we need to ask ourselves the same question. You have a patient on a wheelchair, and he doesn't have a seat belt on, and he feels a little groggy, and he falls down, and he breaks his hip. There is a huge cost to that now. Is it cheaper to have seat belts on all the wheelchairs, or do you want to wait for that fall? Are the bed rails up when you're moving a patient on a stretcher? Are the bed rails up when a patient is in hospital admitted? Quite often, individuals want to go to the toilet at night, and we see this with the elderly all the time. They go at 4 in the morning, and what if they have a fall? Is there a call bell in the washroom to immediately call, and nobody, or otherwise nobody would even come and see them for 2 hours till the next need for the nurse arises for her to go check? What about localized sound-alike medicines? One alphabet here or there, and the medicine could have totally different ways of acting, and a nurse in a hurry picks up that medication. You don't have a check mechanism. You don't have a pharmacist who has oversight of every single prescription. Because they're in a rush or they get disturbed, they give the wrong medicine. The consequences of that. I can go on and on and on about a sample. A lady comes in with a tumor in the breast, and you take a biopsy, same name, another biopsy done at the same time, the biopsy gets missed. And today we use genomics to be able to decide on what therapy to do for that patient. So I can give you hundreds of examples where the cost of an error, one, the cost in rupees, but also the cost in terms of what it does to the patient, to the families, whether it has a physical impact, it has a psychological impact, and what does it do to outcomes. So I think the narrative needs to change. We should reach a stage where every hospital has the basic standards in terms of safety, just like every aircraft we fly in.
Dr. Shetty, let me bring you in here to this debate. Also, sometime you said that, as time passes by, healthcare will also move into homes and into clinics and diagnostic chains. And so when we are discussing affordability and quality, and how does this fit into that context?
So healthcare is definitely evolving, and the way healthcare is being practiced today is very different from what healthcare was 10 years ago, and 10 years from now, I think healthcare will be completely different. one thing that the COVID pandemic has done is also accelerated a change in behavior. So there's definitely been a lot of disruption in terms of behaviors. If you talk of physician behavior, I mean, the same physician who used to be very reluctant to do a video consult and would like to see patient physically, today is very comfortable doing a video consult and wants the patient to only come in if, like what Anupam said, there is an intervention needed or a procedure needed. Similarly, patients are very comfortable being in the comfort of their homes, avoiding a travel of 2 hours, 3 hours, just to come for a routine consult. We've also seen a lot of single specialty hospitals now develop, so you have now mother and child chains, you have IVF infertility chains, you have off-thal chains, you have home care chains. So the way healthcare is going is that patients over a period of time will only come to hospital when there is an intervention needed or a procedure needed. And a lot of healthcare will move out, to OPD diagnostic chains, to home care and standalone daycare centers. So these are all the things that I would say are in the process of evolution. At home, patients have today learned to use point of care devices. So everyone knows what an SpO2 is, how to take their pulse, so this was so common, during the COVID pandemic. In the midst of all this, I think 2-3 important factors that we should consider. One is standardization and validation of all the devices that are getting used. So very often during the COVID as well, we would have people suddenly calling that my SpO2 is 85 or 60 or 50. But sometimes you don't know what kind of pulse oximeters are being used. So in terms of validation is one very, very important factor to consider. The second thing is in terms of data flow. So that is something that is extremely critical, that when patients go from one outpatient to another diagnostic chain and come to a hospital, how does data flow? Right. The important thing is, we need to ensure that this data flows seamlessly. Patients are not made to carry reports of one to the another to another. And that's where the digital health mission, which is being put into place, is something which will go a long way, because at the end of the day, the seamless flow of data will help in reducing errors, will help in reducing duplication, improving quality, improving outcomes. So as healthcare moves out of hospitals to all of these, important thing is that the patient should be considered as one. His data should be confidential, but at the same time be accessible to all the relevant stakeholders. So that's how I think things are going to evolve. But validation, integration, data flow, these are all the things that one needs to keep in mind.
Absolutely. I think we will open up the discussion to the audience, and we welcome any questions for our panelists. Any questions? Right.
We spoke about publishing the data, and I think you mentioned that you will publish it being a listed hospital. But for accredited hospitals in India, NABH as well as BCID hospitals, if the regulatory framework or under the accreditation it becomes mandatory for these hospitals to publish, at least that will be a beginning. And maybe then that can be a criteria for the people to choose the hospital that they would want to go to. So I think if all of us can lobby and push for this thing to happen, I think that will go a long way in taking the next step forward. Thanks.
If I may just, to be honest, at this point of time itself, in the NABH standards, every accredited hospital has to send the data to NABH on a quarterly basis. There are certain indicators for which you have to mandatorily report. Now the challenge, I mean, having seen on the other side also, having been very closely involved with NABH, the challenge on the other side is the inhomogeneity of data. The challenge which any accreditation body faces is when there is a humongous amount of data, but they're not homogeneous. It's a statistical nightmare, as they say. So how are we going to compare institutions unless we are sure that we are comparing apples to apples? And that is the reason as to why, if you look at the NABH standards at least, there's now a defined definition, there's a defined numerator, there's a defined denominator. So the idea is to move towards this, wherein once there's a homogeneity of data, it gets published. So let us say at a Manipal as a network. So we have done this homogenization and we have it as a network level and we are monitoring it on a regular basis. The data goes out to your peers, the data goes out to people who are interested to know our data. We are able to do that, and we are able to say with confidence that the data is accurate only because the systems and the processes that are there to capture the data are accurate. So unless we are sure of that, I would be a bit wary of publishing it, because at the end of the day, we don't want it to become a race where everyone believes that 0 is the ideal number. Let us understand, we are still as a country are yet to reach that stage where we'll accept errors, where we will say that yes, it is possible that the doctor is not at fault, where the hospital is not at fault, but still it happened. So till we reach that stage, I would say we should have a word of caution. We should be very careful about how we go about communicating this. Compared to a lot of other Western countries, a lot of Western accreditation agencies, why do they insist that they be made public? Because they have reached that maturity. So I think we must push the regulators and we must lobby. And importantly, I'll again take a cue from what was told earlier. We should create awareness among the public that, look, if some hospital is stating that they have an issue, they're tackling it, it's not that the hospital is bad. Because why doesn't anyone come forward to state it? Simply because everyone is scared that if I publish, it would be a negative publicity and it would have an adverse impact. I think we are in that journey. We need to wait maybe a year or so more and use this period to create awareness. Thank you.
I think there are two aspects to this. One is that most accreditation systems, including Joint Commission, don't expect you to really measure outcomes. I mean, measuring HAIs is not outcomes. So actually accreditation systems, and I was a surveyor for JCI for several years, and we debated this, that accreditation does not ensure appropriate outcomes. Outcomes are not measured. So that is for each institution to decide. Cleveland measures, Mayo does, the top 10 hospitals in the US do. There are hospitals across the world that do this because they believe they want to go beyond accreditation. For example, we publish our outcomes on our website, and we've been doing that for several years. Our bypass outcomes are reported every month. They go to the board and they're on the website. So all our indices are on the website. But I don't think it can really be linked to accreditation at this point in time unless accreditation itself evolves. Having said that, we also need to address the issue of accreditation. Out of 20,000 hospitals, less than 1,000 are accredited in India, and NABH was established in 2006. So in 16 years, all we've got to is less than 1,000, about 900 or so, and less than 40 of JCI. So the entire accreditation movement, I think, needs to pick up, and we need to push that. And then we need to look at outcomes as being voluntary, because if we expect too much, then there will be too much of a pushback. As it is, accreditation, I think, is really in its infancy in our country, and we need to sort of at least get people to start talking about accreditation, both in the public sector and the private sector.
I'd just like to carry on where Dr. Anupam has just left on accreditation, and I am also a JCI surveyor, and I'm an Artemis Hospital. It's Dr. Devlina is our CEO and at the panel, and I completely agree. I think she first made that point about outcomes and measuring the outcomes. And it's very important to measure the outcomes. In JCI also now we are moving towards their newer standards. So in the latest editions, they are moving towards measuring the outcomes as well. But the point I wanted to really touch upon is the effective training. Effective training. We talk a lot about training. It's emphasized in our hospital as well as all the leading hospitals. And but is it really effective? We're spending a lot of resources, time, money on training. And when we talk about quality, it starts from the bottom to the top. So what happens, we are, as leaders in our respective departments, we are pushing it. But in the lower strata, in the general duty assistants, in the people, a lot of physiotherapy, a lot of people are there who are getting trained, but it is not effective enough. So I think we are talking about information technology and how it leads to changes. I think we need to also consider how we can have more effective, innovative, and continuous processes of training our people, especially the paramedics and the PNs, at that stage. So what is your take on anybody on that?
See, absolutely. I think when we look at the medical community, for example, CME credits, there are, I think, 3 or 4 states that mandate it. And again, your licensing is not linked to that. If you look at nursing, I don't think there is need for any. I think if you look at paramedical, of course, fortunately in the last 3 years, the NMC bill, the nursing bill, and the allied healthcare workers bill, I mean workers bill has come in, so I think there will be some amount of regulation. So one is that there is no, for example, how do you even decide who's a dialysis technician today? There is no registration. So it's all self-training and so on and so forth. So I think firstly, strengthening all these three bodies is extremely important. The second is, like you rightly said, is just doing the credit hours and what have you learned. So unless you have a pre-test and a post-test, you're never going to know. And again, that meets with a lot of opposition the moment you talk about it. Also, if you look at ways of training, we need to embrace technology in terms of simulation. Why should patients be the first, I mean, why should some doctor or nurse for the first time actually cannulate on a patient? Why? I mean, it should be done on,
So technology should
you know,
pervade the
through simulation.
training
Yeah,
also.
absolutely. I mean, there are enough dummy models available for everything, from central lines to whatever, and that's where we really need to move forward, as is done in the West now.
No, and I'm with you, Namita, on this, and we know how the type of emphasis we give to training at all levels, evaluating, reporting a mistake, and all of this is going to happen like what we actually create the culture of safety. You come forward and you say that, you know, you had a spill, but you did not know how to clear it, you know. At that level, you know, I'm not even going at a higher intervention level, but at a lower level, when your GDAs and your nurse, you know, your lower level nursing staff or your paramedics are doing a procedure, making a mistake, they come back and they report, and they report pretty often in our institution. So basically, because you are creating that culture. You can continuously train, but if they are not willing to implement what we think is right, it will never happen. Once it goes into their system, this is how they have to imbibe, this is how they have to work, this is how they have to ensure safety, and this is how they have to report every time they go wrong. That is the point that we have achieved, the culture of safety. And that is what we should, all of us work toward.
At one time, I think a JCI surveyor was stopped outside the ICU in our hospital, and he was asked to perform hand hygiene, and he really commended it. He was very happy with it. So I think that is the percolation and the continuous process, because we are continuously having new staff coming in. Retention is becoming more difficult, and that is the thing where we need technology.
To add to what's already been said, most of for the larger audience, not necessarily for the audience that's there in this room, why are we doing these training sessions? Let's be very clear of the motive. Because in a large chunk of hospitals, these training sessions are being done because someone has mandated it to be done. It's not being done because I actually want to upskill. What is the intent? What is the motive? Once you are very clear on the intent of the training, I think the effectiveness of the training will automatically improve. Another food for thought, and what we have been trying out now in Manipal is, when we work together as a team, why can't we train together as a team? Interprofessional. We still tend to have discipline-specific training. This is the doctor's training. This is the nurse's training. This is the technician's training. When are we going to break these barriers? When are we going to say this is the training for the healthcare team on infection control? This is for the team which is working in that area. I think if we move towards that, it not only leads to better understanding of what our colleagues do, but it also leads to a more effective training. That's been our early experience. Thank you.
I had a question, Karan here from Apollo Hospitals. It's generally to the entire panel. How good a job have we done of communicating value to patients and the broader community? I asked this because during COVID, the medical community, which is well trusted, both the professionals and the institutions are well respected, gained a lot of currency and respect. But I feel it's a fast depleting sentiment now as time goes by. Yesterday there was a news of 4 doctors being, an FIR against 4 doctors for delay in remdesivir being administered and things like that. How good a job of communicating value and trust have we done for the broader community? Thank you.
Well, you've touched upon a very, very important issue. To be honest, we always believe that bad news about healthcare makes it to the front pages of the newspapers, and good news is somewhere, very much inside on the back pages. And it's something that all of us as stakeholders need to work together. Whether it is institutions, whether it is individual doctors, we all need to continuously engage with patients, with community groups, with corporates, to showcase some of the work that we are doing on an ongoing basis. And putting out outcomes is one way of doing it, to be honest. Like many hospitals have started doing it. It's important to put out the good things that we are doing. It is important to put out also the areas that we need to improve on and stuff like that. But this is an ongoing journey. I don't think there is anything which is going to be like a quick fix. But the trust deficit that exists between healthcare, especially private healthcare and the community, I mean, that is the elephant in the room, because there is still the perception that private healthcare is expensive, unnecessary tests are being done, unnecessary procedures are being done, and that can only be resolved over a period of time through effective communication, through communicating outcomes, through continuous engagement with the community. That's what I believe.
If I may just add here, for me, it's a very apt thing. You said, how do we communicate value? I think that how you conduct yourself communicates what you stand for, and you really don't have to really go out there to prove yourself. Because healthcare is all about trust and faith. And here again, I'm at the risk of repeating myself. Go on saying what was taught in our medical schools. Let's stick to it. Let's try and do the best for the patients who come. Let's try and treat as many as we can. Let's keep profits aside and try and help, and rest will follow. So if that becomes your culture, if that gets ingrained to you every single day, it is a long, arduous journey. You might have to tell your investors to wait, or you might have to, in a private sector, you might have to give a different explanation to your board why profits are not showing. But if you're able to buy that time, things automatically fall in place. And I'm telling you, we are a very small hospital. We started with 90 beds in the hub, which is Gurgaon, which has all big brands, all big chains. Today we stand at 600 beds, adding 200 more in the next financial year. These are not great tales I'm trying to tell from this podium, but this is a tale of trust. Why do people still want to come to us? Because we have not gone out there to prove ourselves. We put our heads down and continuously did what we think and thought was the right thing to do for the people. We are probably one of the few hospitals which has an M&M committee, which kind of does a dipstick every 6 weeks to look at any surgeries which has been done, which was not required, over-investigation, over-billing. People are called into a closed room where discussions are held. And what it sends is a strong signal that people are watching. Certain actions and certain way of practice is not going to be allowed in this hospital. We have never chased doctors to get patients. We have only told them to inculcate trust. It's the way you conduct yourself, and people will come and join you. That's my total inherent belief, And sometimes it might be wrong as a business head, but so far, I have not been proven wrong. Thank you.
Right. Any more questions? Okay, the last question here.
Thank you, panelists, for the superb conversation that you have set forth for us. I just wanted to touch upon what Dr. Shetty raised. And you were speaking about how do we ensure that we reach out to other hospitals, pick upon their best practices, share the knowledge, and how do we actually go about doing that? I wanted to hear from you, Dr. Shetty in particular, and maybe the other panelists. How do we set a collaborative workspace wherein we can share our best practices, enjoin other hospitals to follow suit? Thank you.
Right. So with that, we come near the end of the discussion, but not without the closing remarks. Quick closing remarks, starting with you, Dr. Shetty.
Well, I think it was a wonderful discussion, and just to take on from what he just mentioned, these are all forums where there are opportunities for us to collaborate with each other. And clearly, Indian healthcare has shown tremendous resilience during the course of the pandemic. And what we learn from each other is that the kind of public-private collaboration that came through, I think that is something that we will have to continue going forward, because it's a large population with a huge disparity. And unless we use technology and collaboration, there's no way that we'll be able to touch the last village. Thank you.
I will like to applaud the leadership of the week for bringing us all together, for having these awards now 19 years going, and for the methodology you follow, and continue please to engage with healthcare providers, and this is so remarkable, journalism with a human touch, and I'm saying this again, we are always inspired by what we read that you produce, and just a request that make the criteria even tougher so that we get better, make them more international in the look and the feel and the depth of analysis that's done overseas, so that each healthcare provider strives to become better tomorrow than we are today. Thank you so much.
Thank you, sir. Thank you for this opportunity, and it's to have journalists and media speaking in favor of the healthcare team is really, really heartening, and for them to acknowledge us gives us the fillip to surge ahead. And all of us here today as doctors, healthcare providers, administrators, I'm a very optimistic person, and our goal for universal health coverage, quality healthcare for India, it's not specifically about any organization or hospital, and I really want to pitch that hard. And today, all of us should pledge and go beyond our workspaces to see how can we make universal healthcare and quality health for India a dream come true. Thank you.
Thank you. I think I'll again touch upon what Dr. Guleria said. Quality is a journey, and I think we need to sort of mature as we go along in this journey. We need to raise the bar higher. We need to communicate better with our patients. We need to communicate to the community at large the benefits of quality in healthcare. And I would just use two taglines, and these are definitely, I am not trying to promote anyone. Picture abhi baki hai. I think we are just beginning in our journey of quality. We need to further strengthen it, and dil mange more. I think we need to ensure that we don't stop at these laurels. It's good that we have identified certain hospitals are the best hospitals. I can't say bestest, obviously there's no such word, but as I would agree with what Dr. Sibal said, it's time for us to put our heads together and raise the bar so that we still provide, we continue to provide safe, patient-centric quality care. Thank you.
On that note, thank you so much, panelists, for joining us on the stage.
Thank you. I think Dilwa, sorry, one more question. Do we want to take that? No, right? Oh, comment.
Message taken by the panelists. Thank you.
So, thank you. I think it was a very fruitful discussion. Now, can I ask Khush Mohan Joshi, the Senior General Manager, Sales, to come and give mementos to the panelists? Starting with Dr. Devalina Chakravarti, please. It's not. Dr. Santosh Shetty. Thank you. Dr. Sibal. And Dr. Anand R, sorry. Before we conclude, I would like to say that there's lunch on the side, on the right side under the sun. We've had enough food for thought, and now it's time to probably eat. And I would like us to please give the vote of thanks. Where is it?
Afternoon, ladies and gentlemen. We have we've come to the end of this celebration, and it's time to say thank you and goodbye. Today, actually, I'm an enlightened man going back home, listening to this healthy debate on what is quality in healthcare. For me, you know, a layman or a person from the other side, when I visit a doctor, how he speaks to me and how he diagnoses or he decides my treatment is most important than anything else. So which means to say it's his communication, his skill of actually explaining to me in probably very simple words of what the issue is and what the treatment is going to be. But today my mind is open in terms of what quality in healthcare could actually be. I actually, now this is basically because of the trust factor. I took the train ticket without even thinking about whether the train is going to reach the destination or not. So let's go back to to thank our panelists as well as the chief guest of the day. Let me first thank Lieutenant Governor of Delhi, His Excellency, Shri V.K. Saxena, sir. We thank you, sir, for your graceful presence and doing the honor of distributing the winners' prizes. Our guest of honor, Dr. Gleria's presence and his robust speech on quality, ensuring quality in healthcare was a new definition required to be inscribed in our minds forever. Thank you, Doctor, for being with us and sharing the dais on this happy and eventful day. The event would not have been successful without the energized panelists who let us think beyond our small world on quality in healthcare. Thank you, Dr. Shetty, Dr. Anand, Dr. Sibal, and Dr. Chakravarti, for the healthy discussion on our theme for the day. Your insights and opinions have been well absorbed for us at the week to register a new way forward on our concepts and future stories. Week has always been associated with the health fraternity. We are always going to be there with you to share your innovations and your achievements. So please trust in us. Lastly, I must thank each and every person present in this hall who has kept aside their busy schedules and managed to be amongst us for this eventful purpose. Thank you to each one of you. Not to forget the team of the week who have put in their heart and soul into making this a grand success. The list is long, but let me summarize by mentioning thank you to all the editors, the senior correspondents, the regional managers, and the other senior managers who have helped us put this event together. Thank you to one and all. Thank you. We can proceed for lunch.